Good evening and welcome to Mental Health, Insights and Guidelines for General Aviation Pilots. My name is John Collins and I'm the Manager of Aviation Safety Programs here at the AOPA Air Safety Institute. Before we get started with our webinar tonight, I think you're going to enjoy it. We've got a lot of good information packed in here. A few things that we need to cover administratively. First of all, please make sure that your volume is all the way up so that you can hear us. And second, if you have any audio or video issues this evening, we're unable to troubleshoot during the webinar. We found that if you log out and log back in, that generally alleviates the problem. We will be taking questions throughout the webinar this evening, and we'll get to them at a question and answer period at the end of the webinar. In order to make sure that we can get to all of them and not have a lot of detail, we'd ask that you do try to keep them in a broad sense. However, we understand there are a lot of questions around this topic. So if we're unable to answer them on air tonight, we will try to get to them and get you an answer via email. Also, tonight's webinar is available for Wings credit if you signed up using the email address that you used to register at FAAsafety.gov. When you set up your Wings account, you'll automatically get that credit. If you don't remember whether you signed up for this webinar with that account or not, by all means, you can send it to us through the question function and we'll make sure we add you to our list. This webinar is also eligible for an AOPA webinar badge through the AOPA pilot app, and I'll talk more about that at the end of our webinar. So without further ado, I'd like to introduce my boss, Richard McSpadden, Senior Vice President of the AOPA Air Safety Institute. Richard, you have the controls.
Hey, John, thanks for organizing the webinar. This is an interesting topic and a timely topic. We've come so far in just society in general and how we look at mental health. And we've also made some developments in aviation, and I think more to come. It's an area where I think there's a lot of confusion and a lot of misunderstanding, and we hope to clarify that some tonight. And to help do that, we have a really special guest, and that's Dr. Penny Giovanetti. Dr. Giovanetti comes to us to the FAA. She's been there about 10 years or so. She came from private practice, but before that, she was an Air Force flight surgeon. She was in the Air Force for some 27 years, a graduate of the Air Force War College. She has a doctorate in osteopathic medicine, and she has a master's in preventive medicine, and she got her undergrad from Stanford in English. So quite an interesting background she's had and an interesting career. And interesting to the people on this seminar, she also earned a private pilot's license. So we're delighted to have her here. We're delighted that she can help us understand the FAA's posture on mental health and how it's changed through the years. And we'd also encourage you to ask questions. We have some from people that submitted some earlier that we'll have ready, but also your questions are private. The only people that can see them are myself and John Collins and Gary Crump, a medical official with AOPA, and we understand that health issues, including mental health issues, are private to people. So please know that your questions will be held in privacy, and we'll be able to pose them to Dr. Giovanetti. So without anything else, Dr. Giovanetti, thanks so much for this webinar tonight and for joining us.
Oh, absolutely. It's a pleasure. And I very much appreciate the invitation from AOPA to address this issue that is so important and getting so much deserved attention right now, throughout the world, to be honest, with the stresses of pandemic and everything else. But let's get into some material. I kind of prepared some information to share with you so that we can kind of all get on the same foot here and move forward, and I look forward to the questions in the end. Okay, so I didn't know where I was in the air. Something most pilots don't ever want to. And we can't tell from this quote, what's going on. Is this a navigational error? Somebody put in the wrong radial? Is this a sudden entry into IMC conditions unanticipated? Don't know. Or Could it be perhaps spatial disorientation? I don't know if I'm up or if I'm down, or, you know, if I'm where the horizon is. But one thing we do know is that the speaker of this was aware that things were not going well. So what's the most lethal form of spatial disorientation? Unrecognized. So that's going to be an important point to follow through as we continue to talk. Now, I can't see Mr. McSpadden, but he's getting nervous right now because he's thinking we want to talk about mental health and not about spatial disorientation, but it all really comes together. So the author next, the speaker of this quote was actually not a pilot at all. This was the US Olympic gold medalist Simone Biles. And if you think back to the Tokyo Olympics and to all the press surrounding her decision not to compete in several of the events that she was expected to compete and indeed probably win, you will remember that she made a decision after 5 years of training to go back to the Olympics and to maybe perform some maneuvers that no one had performed in that competition before. She said, I'm not safe. And she said, I'm not flying. And this is the aspect that we need to think more about in terms of mental status and how it impacts performance and how it impacts safety. On the other hand, think back now to the Beijing Winter Olympics and think of Kamila Valieva, the Russian skater who was anticipated to take all the gold medals home. She made a very different decision, and without getting into the politics or, you know, the cultural issues about why, she chose to try to fly anyway when her mental status, in fact, was impairing her performance and impairing safety, perhaps. She made a different decision, had a disastrous performance. And so Simone Biles comes home from Tokyo, having earned the respect of the world and a few medals as well. And Kamila Valieva comes home with sympathy. So next. Now, next, please. Now, why are we talking about gymnasts? This is a webinar for pilots, right? This is for aviators. But I think there was a real message for us as aviators in this Olympic story. And that, again, is that we need to be thinking not so much of mental health and mental illness, but as mental status as it impacts performance and as it is a safety factor. And so when you look at what the gymnastic community has done with this sort of thing, you realize that naming it facilitates the ability to talk about it. And they call it the twisties, but it had a name and they could talk about it. And when you can talk about it, then you facilitate recognition of it. And when you recognize it, it decreases your fear of it. And when your fear is decreased, you can take action. And so I think this is the message that we can easily translate into the aviation community. And this is what we're doing right here tonight. We're talking about this. We're reaching a consensus so that we can recognize those times of our lives when our mental status may impact our performance and may impact safety. So next. So mental health, mental wellness, mental illness really exists on a continuum. There really aren't any bright, distinct lines one from the other. And so as we move across this line at various phases of time, what we are needing to do is to move to the left in terms of taking action, to act sooner, act early when we start to notice issues relating to performance and safety. Next. So mental health issues are common. You know, the National Institutes of Mental Health several years ago did a study of, you know, if you look across the US population at any one time, 21% of people have some sort of a mental status issue that ranges, again, on that rainbow diagram that we just looked at, all the way from just on the edge of wellness, all the way through severe illness. 21%. Now, since the pandemic, I have seen some data that suggests that the rates of anxiety and depression are 4 times higher than they were pre-pandemic. 4 times. I mean, that is substantial. So let's look a little bit more at the aviator population. And in 2020, almost 6% of our Class 3 medical certificate holders had at least one mental health code in their record. Small percent, and you wonder why only 6% when you expect the US prevalence at closer to 20%. We could speculate on that, but I don't know for sure. And currently, I'm talking to our general review certification docs down at Oklahoma City. Their estimate is about 30 to 40% of the cases that they're reviewing right now have mental health elements involved. So you can see the just dramatic expansion of either willingness to talk about these issues, willingness to come forward on these issues, or really, you know, exposure and conditions that have increased substantially. Next, please. So our history at the FAA in regard to responding to this kind of continuous growth until we got to the explosive pandemic phase, you know, we've hired our first chief psychiatrist in 1970. And his charter at that point in time was to get the HIMSS program up and running, because at that time there was interest in saying, you know, yes, addiction is a lifelong disease, but that doesn't mean we shouldn't be able to get people back to flying. So the HIMSS program was established in 1974 with support from ALPA, with support from Congress, with support from the FAA. And, you know, it's been a very, very successful program. In 2010 was when we started the SSRI program. We had, again, you know, the airlines come forward and say to us, you know, these pilots that are grounded because of depression and whatever, you know, we look around and they seem to be doing really well, you know, and depression is kind of a common thing, you know, and can we do something? And so we set the program up. Naturally, we set it up to be very conservative in the beginning because we wanted it to succeed. And sure enough, we've been doing very well with that program. It's not just a program for depression. We have folks on SSRI medications for a whole variety of diagnoses, and all of them are fair game. You know, as long as that those medications control symptoms, we're good to go. So 2016, we had the ARC, Aviation Rulemaking Committee, which convened at the direction of the FAA administrator following the Germanwings tragedy. And we had a lot of discussion at that point about what we could do in terms of improved support of mental health of aviators. Now, it was focused admittedly more on the commercial aviators, but the concepts of peer support programs really took flight at that ARC and really gained a lot of support. I'm still waiting. It's still a challenge to figure out how we can provide similar services to our general aviation population. It's difficult. without the resources and organization of an employer and an employee relationship. But think about it. If anybody has ideas, that'd be great. We hired our first neuropsychologist on staff in 2018, to address issues of neurocognitive testing and to do in-house reviews to make sure that we got, consistent opinions regarding results of neuropsych testing. We hired our second FAA psychiatrist in 2019. So it took us, some almost 50 years to go from 1 to 2 psychiatrists, and then only 2 years to go from 2 to 3. And currently, I know that the questions have been asked about why in the world does it take so long to get an answer on some of these cases. The 3 psychiatrists just can't keep up. And what we found was that even though we were using our downtown consultants to review some of these cases, that as we got deeper into the pandemic, they got busier and busier with their private practices and had less and less time to help us with cases. So we are now in the process of recruiting a 4th psychiatrist. So you can see how this is really accelerating. But we're trying to keep up with it. We recognize there's a backlog that we don't like, and we're trying to attack it. So next slide, please. So what's the FAA philosophy? In a pilot with a mental health diagnosis, return him or her to flying as soon as it is safe to do so. This philosophy has been consistent for all 3 federal air surgeons that I've worked for, and I have reason to believe by talking to some folks who've been around longer than I have that this has been the case for even longer than that. So it's not true that we sit around looking for ways to ground pilots. We're far too busy putting pilots back in the air to worry about ways to not put them back in the air. Next. So, we get it. If you look across the leadership in the Office of Aerospace Medicine, all 4 senior executives in the Office of Aerospace Medicine have their private pilot's license. Some of us are not active as we used to be, but we've all been there. We've all had that experience. One of our 3 policy development physicians is a CFI. 2 of our 3 psychiatrists have private pilot license, and the senior regional flight surgeon, the former one, had a private pilot's license as well. So when you're talking to leadership, you're probably talking to a pilot. And so hopefully that helps bridge this gap that seems to be out there between us and them. We as us. Next. So what are we doing to try to reduce this fear of disclosure, or the fear of seeking treatment when it's necessary, or just doing interventions? If we don't get all the way again into the realm of illness, just dealing with stress and other things, taking steps, and not letting something move across that continuum line that we talked about. Keep it on the mild end, address it early, and it is much simpler, much easier to correct. So what are we doing? We've already talked about trying to decrease the backlogs. I mean, it really is a concern, especially of folks that depend on a paycheck coming from their flying. How long it takes is a disincentive to disclose. So not only are we looking at hiring an additional psychiatrist, but we've also been working for some time on a contract to formalize our relationship with some of our consultants so that we can have a more predictable backup, so to speak, when we have a bolus of cases. So what else have we done? Well, we've published recently decision grids for AMEs on both PTSD and adjustment disorders. This is the first time that we have allowed AMEs to issue a subset of individuals with history of these conditions. And we are looking to do more of them. Clearly, you know, everybody that walks into an AME's office wants to walk out with a certificate in their hand and be done, you know, and go fly. So we are looking at all the possible ways that we can increase that and decrease the hassle factor related to decisions regarding mental health. We are currently involved in a research project to evaluate the frequency of cognitive testing. As you well know, all the folks on the SSRI program who are class 3 medical holders need neurocognitive testing every 2 years. We think that's too often, but we need the decision to be data-driven. We've gone through several hundred records, had to go through them by hand manually. We have completed our data gathering process at this point, and so we are about to begin data analysis. I certainly hope to have a decision on adjusting the frequency of this testing by the end of the year. What else? We're looking at evaluating additional mental health medications. Our PharmD, our doctorate level pharmacist who's on our staff, is working with my psychiatry staff to look at potential medications, both from effectiveness standpoint and mostly from a side effects standpoint. The 4 that we have had approved since 2010 were picked specifically because they had a very benign side effect profile. So we're going to look into other newer medications and see what we might propose. Clarify reporting requirements. People continually ask the question, wow, what do I need to report? You know, and the only reason they ask the question is that they really would prefer not to report things because they really don't want to get involved in the hassle factor of dealing with us over a special issuance. So even as we try to decrease the hassle factor, we're looking at how we can be more clear about what really needs to be reported and what does not. A simple way of thinking about what we currently do is that if it's not individual therapy, you know, if it's kind of a group thing like family counseling or even a CISM debrief or follow on, something that's not individual therapy, then we don't need to know about it. But any kind of individual therapy, we still would like reported, and quite frankly, when in doubt, report it, and we'll sort it out. Far better that than not. Trust is a two-way street, and you know, I hear from time to time people say, "Oh, we don't trust the FAA. We don't trust the FAA." And I'll be honest with you, I'm not sure what they mean. I mean, we spend a lot of effort to make sure that our decision making is consistent, is sound. I review every single memo that's written by my psychiatric staff, every single one, just for that reason, to assure the quality of the thought process and to assure consistency, administrative consistency. Now, I'm not a psychiatrist, so I don't review it for, you know, the technical psychiatric piece, but our product coming out should be consistent. And so I really don't understand where the trust issue, what that's all about, except maybe what it means is, well, we can't be sure that we're going to get the answer we want, and therefore, you know, we don't trust the FAA. I don't know what to say about that. I mean, the reality is, with a safety mandate that we have, there are going to be a few people every now and then that we're going to have to give bad news to. But if we can mutually trust each other, this, I think, will move this subject forward in a very positive way. So next. So myth, denial is a common event. If I have any kind of mental health anything, or I get any kind of mental health treatment, or I get therapy, or I get whatever, they're going to ground me forever. Just not true, just not true. Our initial disqualification rate for all mental health diagnoses combined is about 20%. And you say, ooh, that's kind of a lot. Well, I will also point out that this is only the initial disqualification rate. That's not the final word. So frequently I see that we recommend, you know, for an airman who has kind of a turbulent history, you know, let's observe for another year and see if things have really stabilized. Come back and, you know, come back in a year and we'll look at it again. Or come back in 2 years and we'll look at it again. Or come back and bring us an additional evaluation, a current evaluation from a provider, and we'll look at this again. So this is not the end of the road. So the final DQ rate is going to be far lower than 20%. But let me share with you a couple of guidelines that we work from. First of all, in an aviator with substance dependence, we return them to the cockpit once they are in satisfactory recovery. That's it. I mean, that's almost as close as you're going to get to a 100% guarantee. If you put in the work and get in good recovery, you're going to get back in the airplane over and over and over again. I mean, we have individuals who've relapsed 3 and 4 times and get themselves back in solid recovery and get back to flying. We do that. And so the second one is much like this. In an aviator with uncomplicated anxiety, we return them to the cockpit once they are in remission. And so anxiety is also something that can sometimes be chronic, sometimes recurrent. But the promise we make here is that uncomplicated anxiety, we get it back in remission and get it back in control, and you're going to get back in the airplane. Next. So what's the impact of these programs? Well, in 2020, we had 1,510 pilots, that's all classes, flying while taking SSRI medications. And we had 719 pilots flying with a history of substance dependence. I think that's a pretty good track record. Next. So, wanted to take a minute to talk about the no-goes, so to speak. You know, we have a couple. If you have psychosis, if you have bipolar disorder, and if you have personality disorder manifested by repeated overt acts, usually legal issues, it is not likely that you will get a special issuance. But having said that, reminding you that we tried very hard to get to yes, psychosis is disqualifying except when we can find a single trigger that caused the psychosis that can be absolutely avoided going forward. And a good example is a steroid-induced psychosis. Those people will get back in the cockpit. Same thing with bipolar disorder. We've spent a lot of time in conferences and back and forth because sometimes someone will put down in a record diagnosis, maybe it's bipolar disorder. And maybe they're wrong. You know, sometimes it takes tincture of time to really sort out whether that diagnosis is correct. And if we can get to the point where we believe that that was not a correct diagnosis at the time, not because someone goes back to another psychiatrist and gives them a different history about what happened then, but going back to the original record, and we're convinced that bipolar is not the diagnosis, those individuals will be back in the cockpit. Personality disorders, a little more difficult, a little less definite. We do have some, not many, again, where it looks like the overt acts have ceased. It looks like they've learned new coping and adjustment skills and that they're not at risk for continued problematic behaviors. So we've got 1 or 2 of those even that are back in the cockpit. Next. So we are not a black box. Decision making is really very straightforward. It's basic SMS. These are the questions we ask. We got an airman here. How likely is the condition to occur again? And if it occurs again, how serious is it likely to be? And those are the two questions that it all comes down to. Now, having said the two questions are simple, the answers are usually very complex. And so I'll just share with you on the next slide what some of the challenges that we deal with are. So sometimes in trying to decide what the likelihood of the event happening again or how serious it will be if it does, there's really an absence of relevant clinical research to answer that question for us. The questions that we ask in aerospace medicine frequently are not the same questions that folks in regular clinical practice ask. They're generally not the kind of research that big pharma tends to fund. And so sometimes we have to extrapolate as best we can from the available data to the situation at hand. So this is a challenge for us sometimes. The other thing is incomplete and poor quality records. You know, we have no control over the quality of what the community docs are putting in their records. And sometimes, quite frankly, it's disappointing what we see, what we can get. And we have to, again, sometimes extrapolate and take our best guess as to what really went on or is going on. The other thing is a lack of provider objectivity. Yes, you know, we're all on the same side here and we are all pulling for the airmen to get back in the air. But we see it sometimes that the community providers really do sacrifice objectivity in favor of advocacy. And this doesn't help us either. They may leave out information of relevance. They may gloss over history. They may not elicit a full history in the interest of supporting, you know, getting the right answer, so to speak. Get the individual, you know, doesn't have a problem. Well, that doesn't serve safety, you know. It really doesn't serve the individual either. So we need the providers out there, you know, to really take this seriously and be objective, because we can work with almost anything, but we need to know what we're working with. And that's the problem. The other challenge is flawed history that comes from many reasons. Airmen learn, well, if I say this, that doesn't go over very well, so I better make sure that I ask this question, I say this. And so what happens is you get an inconsistent history. That's a problem. I think you can understand that. Again, it takes us back to the question of, we can work with a lot, but we need to know what we're working with. We have to do too much guesswork when we have an inconsistent history. Well, which one was it? Minimization, and that's just common. You know, there are studies out there that look at public, the folks out in the community, and they tend to minimize mental health issues, mental health symptoms as in general, not even pilots. I mean, everybody tends to minimize. And the same thing with poor recollection. The farther you get away from an event, the less unfavorably, and not to use a double negative, but the less unfavorably you recall it. And so you'll tell a better story years on, because that's kind of how you remember it. So we have to deal with that as well. Next. So what are the challenges for you folks? Well, we talked in the beginning, remember about I didn't know where I was in the air, recognizing that something is going on, you know, and there are reasons for not recognizing it. You know, we have a cultural tendency overall to misclassify, misinterpret mental health symptoms. This again was an issue that was brought forward when we were talking in the ARC, that this is common. But if you take it the next step, I mean, especially true in pilots, I have the right stuff, and this clearly is not a mental issue. Well, and that's why I emphasize again and again, let's quit thinking it of its illness, you know? Let's think of it as the mental status that generates performance that impacts safety. And then I think it makes it more palatable to recognize when something is there. And finally, recognizing the issue can really just be a product of the disease. I mean, we know that addictions, it's characteristic of the disease to deceive and deny. We know in psychosis, someone has lost a sense of reality. And again, in personality disorders, some of them really lack insight into the impact of their behaviors. And so it makes it very difficult to recognize. But if we can move past that first step and we can recognize it and we can say, like Simone Biles, I'm not safe to fly, then the decision to take action. And what I would remind you of is once you've recognized an issue, 6153 applies, and that says that if you know or have reason to know that you have something that impairs your ability to perform the duties of your certificates, you should not fly. So that decision to take action, it rests in your hands initially. And there's all kinds of actions. I mean, taking action doesn't mean making an appointment with your local psychiatrist. You know, again, if we're back on that continuum, closer to the green side, you know, maybe all it is saying, you know, I need to go spend some more time at the gym and decompress. Or, you know, maybe I need to, you know, take my wife or husband out to dinner, you know, so we can just talk and relax. Maybe I need to talk to my pastor. Maybe I need, if I had access to a peer support program, maybe I just need to give them a call, you know, and talk it over. You know, maybe I do need to see my primary care doctor or my AME or a counselor or a psychiatrist. There's a whole spectrum of actions, but the decision to do something is critical. So the next thing you know, is clearly a challenge is the decision to disclose. I mean, we've got good data that pilots in general delay seeking treatment, delay taking action, and we think it all relates to this disclosure thing. Oh, I can't go do that because I don't want to have to tell the FAA. We got to fix that somehow. So the decision to disclose, you know, all that does, or rather the decision not to disclose, all that does is really create more stress, because now on top of the thing that's causing the stress in the first place, you now have the added stress of what happens if they find out that I didn't disclose it. It's not a good thing. And so, you know, I just really encourage folks not to do that for your own best interest. Selecting your mental health team. That's much harder for you folks in general aviation than for, you know, the professional pilots that work for airlines that have lots of referral sources and people to help them make those decisions, who's good to go see, who's not. But I would say it's important to, number one, find someone that's at least familiar with aviation standards, because here's what we find a lot, and people get really frustrated. You know, you'll go see a provider downtown and, you know, they'll do a report, say, you know, I think this individual is fine to return to flying. And then it comes to us, and then we say, oh, not so fast. And then you folks are left confused. Well, you know, the downtown provider said I was fine. Where are you guys coming from saying I'm not? We just deal with a different set of requirements and a different set of expectations. And the expectations for our flyers are higher than, you know, for somebody who just needs to operate normal activities of daily living, maybe drive a car, whatever. So keep that in mind when selecting your team. Be sure it's someone you have good chemistry with. You know, there's got to be a positive therapeutic relationship, which is very important. And a HIMSS AME is probably a real asset if you're working a mental health issue with the FAA, because they do it all the time. They work with the addiction folks, they work with the antidepressant program. They're just more experienced, more facile, probably better able, you know, to point you in the right direction toward getting the right consults. And finally, supplying medical records. Oh my gosh, you know, this was when you get the infamous letter that says, oh, you know, we've reviewed your record and we are unable to determine your eligibility, and please send us XYZ. Please, please, please read that very carefully. Please take it with you to the providers that you're going to see. I'll give you one anecdote. I was answering a congressional, and I'm looking through the records, seeing what's going on. I'm seeing all this correspondence back and forth between the airmen and Oklahoma City, and I says to myself, I don't think this airman understands what we're asking for. So I called him up and I said, sir, we need this thing. And he said, oh, that's what you need? And he had it to me the next day. So yeah, it's paying careful attention to get us the right stuff. It just makes things so much more simple. So next slide. So what would I like you to take away from this discussion before we move to the questions? First of all, mental status is a performance issue and a safety issue. Mental health issues are common. You know, look around, you're going to find more of it than you think. Permanent grounding is rare. All of these kinds of issues are better addressed early. Trust is a two-way street. We continue at the FAA to look for ways to help drive out fear from this process. And finally, take care of each other. You know, sometimes something you don't think of in your buddy down at the FBO, yeah, you know, I've noticed this going on with you. Are you okay? You know, take care of each other. We're one community. We really are. And if I could, you know, wave a magic wand, I would love for us to get to the point where both the regulators and the pilots all feel like we're on the same team. Next slide. And all headed in the same direction. So with that, Mr. McSpadden, over to you for questions.
All right, Dr. Giovanetti, thank you so much. You know, trust, I think, especially in an issue like this, begins with understanding and some transparency. And presentations like yours and your willingness to address some of these issues head on, I think, helps that trust issue because people see the transparency. And for pilots, it's a real challenge because you don't want to step into the unknown because of the potential consequences of either losing your livelihood or losing this thing that you love that you pursued maybe for a life. So I would like to start with one question that's fairly common, and it is, if a pilot self-diagnoses with depression, or even if they're diagnosed with depression, are they obligated to report that? And if so, when? Immediately or at their next physical? Or are they only, let me stop there because then there's a follow-on question about what if meds are involved.
Okay. Remember what I said about 6153. So at the point where you can identify that this condition may be impacting your performance and your safety, you have an obligation to discontinue. You do not have an obligation to report it to us immediately. You would report it at the next physical exam. For folks that have an every 5-year physical exam, that could be a long time. But no, you're not required.
Now, what if that diagnosis involves a prescription for medication?
Same principle. You know, if you're taking a medication that may impact your performance, then you need to stop flying.
Okay.
Ask the question, get with your AME and say, hey, is this a medication that we're concerned about? Or am I good to go? You know, that real-time check with the AME can be very, very helpful, because sometimes you're not sure.
Yeah. One of the big concerns is the amount of time that it takes for an SI. So I was encouraged by the stats that you showed and the overall philosophy that very few people really percentage-wise get permanently grounded. Why does the SI process take so long, and is there any move in the FAA to speed that up?
Yeah, well, I think I showed that when we talked about, you know, recruiting a fourth psychiatrist, because I don't see any way to improve the efficiency. I just don't have enough people to review the records and review the cases. I mean, because they're also doing teaching, and they're also supporting legal and doing lots of other things. So we've really come to the point where 3 is just not sufficient, and it really did hamstring us a bit when the consultants had to kind of pull back on the help they were able to offer. And I think that kind of accelerated the buildup of the backlog. I'd love to have it down to 60 days. I really would. It seems like every time we start creeping up and getting close, something else happens, and boom, you know, here comes the backlog again.
So one of the great, I think, advances that we've seen is the FAA just published a new guidance on situational depression, adjustment disorder with depressed mood or minor depression, and that seemed like a big step. And I know you addressed that a little bit, but somebody followed up on that. Can you just talk about that, with the FAA distinguishing now between less severe cases of depressive illnesses and stuff that is, more severe or more consequential?
Yeah, I mean, I'm not sure exactly what the intention of the question was. We're clearly looking for ways that we can identify a subset of folks with these histories to say, these are not high-risk people. Back to the SMS questions again, what's the likelihood it's going to occur again? And if it occurs again, how severe is it likely to be? And so when we can kind of make that risk assessment and say, no, this is probably approaching the level of the normal population, then we're looking for ways the AME can just go ahead and issue.
Great. Here's another question on counseling. If someone is undergoing mental health counseling, does that automatically mean a action will be taken on their medical certificate?
No, not at all. But remember, again, 6153, you have an obligation to not be flying if that condition that has taken you to counseling might be impacting your performance. Again, we don't know in large part that counseling is taking place until you get to your next exam, where you now reported on your 8500, and now we say, okay, looking forward with this condition, we catch up on the background. Okay, what happened? Where are we? Okay, now let's project forward. Is this a high-risk condition going forward? Because we're going to assume that you've made the right decision in terms of your own flying up to that point.
And when does the FAA consider that kind of old news or previously reported?
Previously reported no change, I think sometimes gets overused. In a condition like depression or anxiety or whatever, I mean, we would always like for the AME to make a comment in Block 60 about how things are going. Have had no problems, have had no symptoms, whatever. I think it's important for us to have that follow-up in an individual in whom we've already identified. Now, If it's a special issuance, well, then that special issuance is going to continue until we feel like the condition is resolved. And many of these just don't resolve. There's always some level of risk of recurrence.
Here's a question on medications, and I think the question is, when will the FAA begin accepting the use of other well-proven mental health medications? And I think broader, this may allow you to speak to just the process of how you go through looking at medications and whether or not you can approve them or accept them.
Yeah. As I mentioned, we're actively looking right now at the more common medications in different categories from SSRIs. We're looking at SNRIs. And the important thing tends to be the side effect profile. The efficacy, you know, we kind of leave that up to the FDA. But really the important thing for us is the side effect profile. And so our pharmacist, our doctorate level pharmacist, usually does a very thorough literature search, looks through all the FDA documents related to the approval of that medication. And then, you know, we sit down with our flight surgeons and our psychiatrists and say, you know, okay, what's the risk here? And is that an acceptable risk? And we take it to the federal air surgeon and we make a recommendation. Yes, we think it's an acceptable risk, or no, we don't. And then that's how something gets identified as acceptable or not acceptable.
Okay, great. How likely is it once a pilot has discontinued meds and they present a stable evaluation after 60 days or so, how likely is it that they will receive a regular issuance medical?
It really depends on the history. And anybody that's looked into the SSRI program, you know, has read that piece about, you know, the 60-day kind of thing. If we have an individual who's been on SSRIs for, say, 5 years, you know, and now they decide they want to get their pilot's license, and oh gosh, you know, I'm going to come off my medicine because I don't want to deal with the hassle of getting special issuance. Those we are very nervous about, and we're probably going to ask for some follow-up documentation, a follow-up evaluation, because that's not something driven by the condition, that's something driven artificially. And that person is better off to remain on their treatment than to stop it. And they're more likely to get unstable, they're more likely to have recurrence if they do that. So it's a bad decision to do that. Yeah. And so your question about unrestricted medical certificate, where that's likely to happen is somebody who, say, adjustment disorder, going back to the mild spectrum things, had an adjustment disorder, they were on, you know, SSRIs for maybe 60 days because their primary care doc, you know, was aggressive with, you know, treatment, and they're off, and they've been off 2 years and their life is fine and all is well. That individual is likely to get an unrestricted medical certificate. And then, you know, every possible combination in between, but those are just, you know, kind of 2 examples for you.
I think you answered this one, but the question is, what are some factors in an applicant's history that would not be viewed favorably for a special issuance? You mentioned psychosis and bipolar disorder. Are there any other less severe sort of symptoms that you look for that would be viewed unfavorably?
Yeah, and unfavorably, again, is a relative term. I like to call them yellow flags. You know, something that makes us pause and look a little harder. Things like hospitalizations, things like suicide attempts or gestures, things like needing multiple medications in order to control symptoms. Those are all things that give us pause. Not that we would say no because of them. So, for example, we do have some folks that we return to the cockpit who made frank suicide attempts, but we have to fit those risk factors into the whole picture and say, okay, you know, what what's with this individual? What do we think is their risk going forward?
Okay, here's an interesting question. On the medical application, the question is, are you currently taking medication? And the questioner is asking, what is the time frame for currently? Suppose you took something 5 months earlier and you've been off it for a couple months. Does that qualify as a reportable?
Currently means right now. You know, I took some before I came to see Dr. AME.
Okay, that's clear
That doesn't
enough.
mean I decided to skip it for a week so that I could say, oh, I'm not currently taking it. You know, if it's something you're consistently taking and expected to be consistently taken by your treating physician, then that would be considered, you know, a current medication. If hopefully that is not confusing.
Here's a question on stuff other than depression. We've talked a lot about depression and anxiety. What about some other mental health conditions that have seemed to grow during the pandemic, like ADHD, that spiked during the COVID era? And are you looking into that in any way?
Yes, interesting that you mentioned ADHD, and I wouldn't say that ADHD spiked during the pandemic. I would say that what's happened is we've got a lot of young folks interested in becoming pilots. And I'll tell you, you know, we've seen a whole lot more cases come our way of young potential pilots with that history of ADHD. So we're seeing more of it in the cases we're looking at, but I don't think it's related to the pandemic. Now, it's always a problem. Was it a correct diagnosis or was it not? And that's one of the first things we ask. And when it's not really possible to tease that out from the history, then we frequently will send these individuals for a battery of neuropsychological testing, which kind of gives us a view of, okay, you know, some of those impulsiveness and inability to focus features can come out in some of this testing that we do. Now, furthermore, recognizing again that there's a lot of demand around this issue and a lot of concern, Dr. Randy George Miller, who is our staff neuropsychologist, has been working with our consultant neuropsychologists to come up with a document to help us define better how to handle these individuals who come with this history of ADHD. So there's more to come soon. I would say in the next few months, we'll probably have some more detail on addressing that particular diagnosis.
Great news on that. Just a couple more questions. One, and there are many more questions than we have the ability to answer. We're trying to answer some online, and for those of you who are asking the questions, if our medical experts at AOPA can answer them, we will. If not, we'll reach out to the FAA and see if we can seek the answers you're looking. But tons of questions, which just indicates how important this topic is, Dr. Giovanetti. So again, appreciative of your time and your candor. Last two questions. One, does the timeline for a review get shortened for a Class 1 or Class 2 professional pilot? So do they get some priority when their livelihoods at stake as opposed to a GA pilot flying on a Class 3?
Yeah, we try to balance that, and we don't uniformly give preference to Class 1 and Class 2, but we do to some degree. I would say one of my 3 psychiatrists always picks the oldest case out of the box. That's the way he manages the queue. One of my psychiatrists does focus on the Class 1, Class 2 folks who depend on for their livelihood. And the third one, that half the time he's responding to consult requests from AMCD on, hey, can you help us with this case? So it's a mixed bag. But we really, you know, we are really conscious of, I mean, if we totally focused on Class 1s, I mean, no Class 3s would be getting done right now. And that's not what's happening.
Yeah. Yeah. One final question. It's an interesting one, and it tags to a book I read a while ago, a book called How to Open Your Mind. And the questioner is asking about, is the FAA looking into research that MIT and I think Stanford is doing in regard to psychedelic drugs? I know there's a more technical name for them, but they've shown some real promise in helping with anxiety and depression. And is the FAA looking at those or willing to look at some of that research coming out of MIT and Stanford?
Our chief psychiatrist is aware of it. Part of the problem is some of those drugs are still listed as Schedule 1. So that means they're strictly research. I think until this research gets more mainstream and we begin to see it used clinically, I don't think we're going to consider it as an option.
Yeah, yeah, understandable. Just watch how the research goes and what the results see. So
exactly.
Yeah. Well, great. Well, so many more questions, but that's all we have time for tonight. Dr. Giovanetti, thank you so much for your service to the aviation community and to our nation in the Air Force. And it was a pleasure spending time with you, and we appreciate your time tonight.
Oh, you are most welcome. And anytime you want to do this again, just let me know.
Great, thank you. I'll turn it over to John for the listeners now. John can help sort of take us out and give you some instruction on following up on your questions and your FAA Wings credit if you'd like. So John, if you don't mind coming back on, take us home.
Not at all. Thank you, Richard. Appreciate that. Thank you, Dr. Giovanetti. Really appreciate your time tonight. And as Richard said, your candor and all your answers and the insight into what's going on in pilot mental health at the FAA and how it's improving and how we can continue to improve that. For those of you that are watching, you can see, please contact us medicalassist@aopa.org. If you have further questions after this webinar, by all means, please get those into us. Our medical folks will answer those questions for you. There have been a number of questions related to how do I get my FAA Wings credit. As a reminder, if you signed up for tonight's webinar using the email associated with your FAAsafety.gov account, your Wings account, you'll automatically get that. If you didn't, or if you don't recall, just submit it to us in the question field and we will add you to that list. At the beginning of the webinar, I mentioned our AOPA Pilot Passport badge. If you use the AOPA app, there is a section in there called the Pilot Passport. If you go to that app and you go up into either the upper corner where the 2 is pointing to, or you use the quick link where the item 1 is pointing to, you can get into My Passport, and you'll see there item 3. You just tap on that, and that'll open up your points and badges. And down at the very bottom of that page, you'll see enter affiliate code. Tap on that. The next page will come up, item 5. That's where you want to enter the code that you see on the screen, ASI Web 062322. Again, that's the webinar badge code, and that is ASI Web 062322. That will be valid until the end of the month. So you have a little bit of time to get that in there. Then if you would also like to add this to your ASI transcript and get a certificate of completion for watching the webinar, you can use the link that is shown on the screen. That will take you into our online learning center and you'll be able to download that application. This webinar has been recorded. We will post it on our website tomorrow, and that will be available at webinars.aopa.org if you'd like to review it or share it with your friends. Again, webinars.aopa.org, and that should be available about noontime tomorrow. I do want to thank everybody for coming. You may not be aware of this, but our safety education is primarily funded through generous donations to the AOPA Foundation. If you'd like to help, you can do that by going online to aopafoundation.org and clicking on the button to donate. There are a number of different ways you can donate to this program, to the Air Safety Institute, and help fund our work. And we really appreciate that. Also, if you are not an AOPA member, and I hope you are, because you get all kinds of good member benefits like our pilot hotline and our magazines and access to our online content. If you're not a member, please consider joining at aopa.org/join today. We'd really appreciate you becoming part of the largest general aviation organization in the world, and I think one of the best, if not the best. So on behalf of Richard and Dr. Giovanetti, myself, AOPA, and Gary Crump, silently working hard behind the scene here to answer a lot of your questions, I want to say thank you for watching. Have a good night and fly safe.